The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everybody, and welcome to another edition of the RX Question Lab. I'm your host, Jeff, and tonight we are thrilled to have you with us as we embark on a journey to enhance our ability to tackle board-style questions with a focus on immunology. So, as you know, we firmly believe that answering NBME style questions is one of the highest yield activities you can engage in while studying for these exams. We also know that questions can be complex, and without the right approach, sometimes they can feel insurmountable. So that's why we're here. Our mission is to help you develop some of the necessary skills to dissect these board style questions effectively and efficiently. And we're going to try to break them down together in real time. Okay, so you'll have the chance to hopefully learn a little bit from us, and then you can also ask questions. I am joined tonight by Kate, who is going to be, answering your questions there in the question box. So if anything comes up, or if we've got questions for you, that's where we're going to ask you to go. Okay, so. Anyway, grab your notebooks, open up your minds. Let's see if we can get ready for a productive session. Make the most of this opportunity on a Tuesday night. So our methods tonight are going to mirror the way that we often suggest that students tackle questions. Now, let me just say there are lots of different ways in which you can approach these questions. Lots of different methods. But the one thing I just want to stress is that whether you follow our guidance or tailor it to meet your own needs, well, the main thing is like you just want to get into the habit of tackling these questions in a similar way, so that you're not changing your style, right, or changing your your habits in the middle of a quiz or middle of a test. You really just want to become methodical, because that will allow you to become just stronger test taking machines. Okay, so with that, we're going to go ahead and start with question number one. And what you're going to notice here as soon as I open this up is, what's missing? We're missing the answer choices, and that's by design. We encourage you to cover up those answer choices, and the reason we do that is because we don't want you to get freaked out if you see an answer choice that you're unfamiliar with, or you see a concept or a topic or a bug or a drug that you just can't remember, or you're like, that's given you troubles in the past. Well, what we want you to do is focus in a stepwise manner on how you're going to slice and dice the question. So first tip is that we say, first step is cover up those answer choices, and then second, read the lead-in. Now, the lead-in is the question part of the question, and in this case, the lead-in is, which of the following is the most likely pathophysiologic mechanism of this patient's anemia? Okay, so reason we want you to read the lead-in is that it's going to help you focus on what kind of information that you're looking for. So in this case, you already know that the patient has anemia. Okay, now you're already off to a good start. You're already kind of thinking through what might be going on here, and what kind of answer you're going to need to select. Okay, so read that lead in first, and now we go and read the vignette. A 14-year-old boy is brought to the clinic because of a 1-week history of low-grade fever, dry cough, and fatigue. His mother says that his older brother was ill with similar symptoms 3 weeks ago during the start of their winter holidays. Temperature is 37.8. Physical examination shows mild nasal congestion, mild pharyngeal erythema, and bilateral pulmonary wheezes. There are bilateral diffuse infiltrates on X-ray of the chest. CBC shows mild anemia. Direct antiglobulin or Coombs test is positive. Okay, so again, the question: which of the following is the most likely pathophysiologic mechanism of this patient's anemia? Okay, so what we're going to do is we're going to go to I'm going to put the answer choices up, but I also want to to kind of note what kind of information you might want to be focusing on here in in that vignette, right? So first off, you got a 14-year-old boy, right? So you've got this adolescent, 1 week history of low-grade fever, dry cough, and fatigue. That's all relevant. Older brother had similar symptoms 3 weeks ago, right? So okay, what's going on in the environment? Mild nasal congestion, mild pharyngeal erythema, bilateral pulmonary wheezes, all important. What's that chest X-ray telling you? And then obviously the mild anemia and the positive Coombs test. Okay, so let's look at those answer choices. And when we look at the answer choices, we read them from bottom to top. We want you to be deliberate in how you look at those answer options. So we start from E and we work our way up to A. So answer choice E, increased hepcidin release. D, glucose 6-phosphate dehydrogenase deficiency. C, direct microorganism mediated cell lysis. B, cross-reactive IgM. A, cross-reactive IgG. Okay, so think about that. You can let us know down in the question box if you want to, how many steps you think it's going to take to solve this one. I should have asked you that before we put up the answer choices, but feel free to let us know there. What I'm going to do is I'm going to go ahead and launch the poll, and you can let us know what you think is the most likely pathophysiologic mechanism of this 14-year-old boy's anemia. So go ahead, take a shot. Let us know what you think. Okay, I see the answers coming in. Okay, about almost 3/4 of you have voted, so I'll give you just a couple more seconds, and then we're going to close the poll. Okay, let's close it, and let's share the results. And a lot of votes here for cross-reactive IgM. Also, some folks were thinking answer choice C, with the direct microorganism mediated cell lysis, and then some also cross-reactive immunoglobulin G. Okay, so let's hide the results and share the answer. And you guys got it right. Great way to start the night. Cross-reactive IgM is the correct answer. Well done, everyone. That's a good way to start off the evening. Didn't get it right. That's okay. That's why we're here. We're gonna kind of walk through it, right? So I don't know, any thoughts there on the diagnosis? Head on down to the question box. Let me know what you think that diagnosis is. And I saw a couple of folks who noted that they think this is kind of a two-step question. Okay, well, the patient most likely has atypical pneumonia due to mycoplasma pneumonia. Um, so this is consistent with the patient's age. It's 14, and all of those symptoms that you were seeing, right? And I'm seeing some of the answers in from Laura and Dominique. That's great, thank you. So the symptoms of you get the low-grade fever, cough, and the fatigue after being exposed to a sick family member. And plus you've got all of the physical exam findings, and then the X-ray of the chest, it might show bilateral diffuse infiltrates, as we saw in this patient. So there's your diagnosis, right? Now, what's the mechanism? So mycoplasma infection, this can result in cold agglutinin disease, secondary to IgM autoantibody production. So, the IgM cold agglutinin, it binds to the cognate antigen, usually the I antigen. So it binds, on the surface of the red blood cells in the sites of the body where the temperature is low enough to be in the thermal range of that antibody. So, that bound IgM, it recruits all the components of the classical pathway of complement, and the complement system is activated. So what happens then, right? That activation induces some of that extravascular hemolysis, and the resultant anemia, right? So we knew the patient has anemia. So that and that positive direct Coombs test is the result of that IgM against I antigen on the red blood cells. Okay. So, looking at those other answer choices, so the increased hepcidin release, that would be indicative of anemia that's, due to like a chronic disease as a result of long-term inflammation. Okay, so what might that be, right? You're thinking maybe like rheumatoid arthritis or inflammatory bowel disease, and that this kind of the kind of inflammation that'll lead to iron sequestration, right? So it's that would be a mechanism of non-hemolytic anemia. Let's see, the glucose 6-phosphate dehydrogenase deficiency, that's a genetic disease, right? So that causes hemolytic anemia in the setting of oxidative stress. So might be like an example might be sulfa drugs, right? So that presents as fatigue, but you see jaundice, you'd see dark urine, and back pain. Okay, so not many chose that one, and that's part of the reason why, right? Let's see, direct microorganism mediated cell lysis. So that describes, malaria or babesiosis, in which you've got the intra-erythrocytic microorganisms that cause the lysis of red blood cells. So, that's going to present with a higher fever than you saw here. Only had 100-degree fever, 37.8. And this would also sometimes present with jaundice. So, what's the final one here? The cross-reactive immunoglobulin G antibodies. Now, these are typically involved in warm AIHA, precipitated by medications, systemic lupus erythematosus, or CLL, chronic lymphocytic leukemia. Okay. So, Anyway, good job. You guys did a nice job with that one. That's a good way to start off the evening. And what we're going to do is we're going to see if we can keep it up here. Okay, so let's go ahead and go to question number 2. Okay, so again, we've got the answer choices covered up, and we do have uh, an 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 X-ray here, right? So we've got. We'll start with the lead-in. So, which of the following best describes the pathogenesis of this child's condition? Okay, so again, we're looking for, how did this start? And we know that it's a child, right? So, with that, let's go ahead and read the vignette. So, a 3-month-old boy is brought to the pediatrician by his father because of persistent cough and shortness of breath. He has a history of recurrent pneumonia, including pneumocystis infection and a persistent diaper rash caused by the pathogen shown. An X-ray shows a lack of a thymic shadow. Blood cell analysis shows decreased B and T lymphocytes. So again, which of the following best describes the pathogenesis of this child's condition? Okay, why don't you head down to the question box. Let me know how many steps you think it's going to take to crack this one. And let's take a look at some of the answer choices here. So again, you're kind of looking at this in terms of what really stands out from this particular vignette. I don't know. I mean, I think a lot of it here is pretty, pretty straightforward in terms of, hey, it's a 3-month-old boy. You've got the persistent cough, shortness of breath, the history of recurrent pneumonia, that persistent diaper rash. What's causing it, right? Lack of a thymic shadow on X-ray, and the decreased B and T lymphocytes in the blood. So a lot of information that you're getting there. So let's go ahead and look at those answer choices. So answer choice E, upregulation of de novo purine synthesis. D, reduced nicotinamide adenine dinucleotide phosphate oxidase. Answer choice C, mutations in the gene encoding Bruton tyrosine kinase. Answer choice B, mutations in the T lymphocyte CD40L protein. And answer choice A, adenosine deaminase deficiency. Okay, so think about that. Take a look at that image again. Let us know what your well. I'm going to launch the poll here, and then I'm going to have you say, let us know what you're thinking. What best describes the pathogenesis of this child's condition. I love all these questions that have multiple 17-syllable words in there. Thank you for all of your patience, all of your support out there. Appreciate everyone letting us know how many steps they think this one is. Okay, let's take a look. Over half of you have voted. I do want to note that we are going to have a raffle at the end of tonight's session. Somebody is going to walk away with a 3-month subscription to RX 360 Plus. So that will be helpful, certainly. So stick around. We've also got some other fun things to share with you. So hang in there tonight. Okay, over 3/4 of you have voted. I'm going to go ahead and get ready to close the poll, which I'm going to do right now. Looks like we've got a pretty clear favorite again. So let me share those results. So over half of you went with answer choice A. adenosine deaminase deficiency. About a quarter of you went with answer choice B, that the mutations in the T lymphocyte CD40L protein. And some of you went with answer choice C. Okay, well, that's great. Let's see what the answer is. And the answer is indeed answer choice A. So well done. This question a little tougher. I know it may have tripped up a few more of you, and that's okay. What we're going to do is we're going to take a look at it and figure out what's going on here. Okay, so this infant is presenting with multiple opportunistic infection, right? The baby lacks a thymus and has reduced numbers of B and T cells. So, what are you thinking? Let's see. Van thinks it is severe combined immunodeficiency, and Van is correct. That's right. So that it all points to this complete lack of an adaptive immune system, and that points us to severe combined immunodeficiency, or a CID. So now we've got the disease diagnosis. Let's think about what the mechanisms are. So a CID may be a result of a variety of genetic mutations, with one of the most common being adenosine deaminase deficiency. So what's the deal with this? Well, patients with ADA deficiency are prone to candida infections. So that's what you're seeing in the image here. They're also prone to pneumocystis pneumonia. So the ADA enzyme is really it's a requirement for purine nucleotide breakdown. So the lack of ADA, it leads to just this building really high level of deoxyadenosine triphosphate, and that buildup blocks off and inhibits the production of other nucleotides. So all of this action is absolutely toxic to rapidly proliferating cells, right? For example, developing lymphocytes. So this leads to the development of these profound T and B lymphocyte immunodeficiencies, which you see here. So great job on that one. Let's look at those other answer choices, though. Upregulation of de novo purine synthesis. So the upregulation of this pathway, not typically associated with immunodeficiency syndromes like SCID. And I don't think many people voted for that one. Answer choice D, again, this defect is seen in chronic granulomatous disease. Oh my gosh, I'm tripping over myself here. And this affects the phagocyte function. Doesn't cause a severe reduction in B and T cells. The answer choice C. So this mutation that's described here causes X-linked agammaglobulinemia, XLA, and that primarily affects B cells. So patients with XLA have almost no mature B cells, and greatly reduced immunoglobulins of all classes. And then answer choice B, about a quarter of you went with this one. So this mutation leads to hyper IgM syndrome, and that primarily affects T cell dependent B cell functions. So patients usually have normal or elevated IgM levels and decreased IgG, IgA, and IgE levels. It doesn't typically present with an absence of the thymic shadow, right? That you see that we talked about here. Also, usually doesn't present with a severe reduction in T cells. So, for this one to be correct, the clinical picture would need to show defects in class switching and susceptibility to encapsulated bacteria, right? Okay, well, this is great. You guys did a nice job with this one, and we are halfway through. So take a quick breather. I want to note that tomorrow night, Dr. Tao Li is going to lead us through a path to USMLE success webinar, and I'm going to put the link here in the chat. So, Dr. Li, the senior editor of First Aid, is going to, he's going to talk through all of the, the things that you need to know about step one. He's going to give you lots of tips, especially how to tackle, different subjects within step one, and talk about all kinds of different resources out there. And we'll also have another raffle. So if you haven't signed up yet, I'm sure some of you probably heard about it, but you can go ahead and sign up. It's going to be tomorrow night. So same time as tonight, tomorrow night. And that's Wednesday. For those of you, some of you may already be Wednesday's already arrived for some of you. So it's going to be 24 hours from now. Okay, so make sure you get set up there. Okay, with that, we're off to question 3. So we're in the second half of the evening, and we'll see if how you guys do here with these questions. So question number 3. Again, we've got the answer choices covered up, and the lead-in is abnormal populations of which of the following cell types characterizes this patient's most likely disease? Okay, so again, we're thinking about cells, thinking about cell types. We have to figure out what this patient has. So let's go and read the vignette. A 67-year-old man comes to the office with a 6-month history of increasing weakness and unintentional weight loss. Physical examination reveals a palpable spleen tip, an enlarged liver, and fixed and enlarged cervical, axillary, and inguinal lymph nodes. A peripheral blood smear is shown. So you can see that here. So the question, abnormal populations of which of the following cell types characterizes this patient's most likely disease? You can head down to the question box. Let us know how many steps, and we'll go from there. Okay, so let's take a look at this one. Again, what what kind of information is that that you're going to be keen on here. Obviously, you've got the age of this patient. You've got the 6-month history of increasing weakness and unintentional weight loss. That's key. The palpable spleen tip, enlarged liver, and then the fixed and enlarged cervical, axillary, and inguinal lymph nodes, and then obviously what you're looking at here in the smear. So with that, let's go ahead and take a look at the answer choices. So we're going to take them from the bottom. Answer choice E, T lymphoblasts. Answer choice D, promyelocytes. Answer choice C, plasma cell. B, metamyelocyte. Or A, B cells. Okay, so with that, I'm going to launch the poll. And I want everyone here to let us know what you think. Which of these cells, an abnormal population of which, would characterize the patient's most likely disease. So as you're doing that, I appreciate all of the comments that we were getting in the question box tonight. Great to hear all of your feedback and your suggestions. Thank you for that. Let's see here. Go to, let's see, about half of you have voted so far. Okay. We're getting close. Everyone's a little slower on this one. I don't think that we've got a clear favorite. So maybe folks are taking a little bit more time. Okay, well, we've got 3/4 of you have voted, so I'm going to close the poll. And let's take a look at the results here. So this is interesting, right? We've got a very even split. Every answer choice got double digits, and pretty neck and neck there between B cells and plasma cells for the top vote getter. Okay, very good, very interesting. So let's go ahead and take a look at the answer. And the answer is answer choice A, B cells. So that counts. That counts as a win for for the audience tonight because B cells just narrowly beat out plasma cells, but it was close. So this question was a little bit more challenging. So let's see if we can walk through it. Okay. So so what do we have here? Anyone want to take a guess here at that diagnosis? Let's see, Van has weighed in again, and Kayla has, and let's see others. Okay, great. So so something popped up that helped push them in the right direction. So this patient likely has CLL, right? Chronic lymphocytic leukemia or small lymphocytic lymphoma. So CLL, SLL. Given his what do we got? We've got the weakness, right? We've got weight loss, lymphadenopathy, hepatosplenomegaly, and the damaged lymphocytes. So what you're seeing there on that smear, you see those smudge cells. So that's that's part of the giveaway here. So CLL and SLL represent different clinical manifestations of the same disease. So CLL seen in the blood, SLL seen in the lymph nodes, right? Both of them usually occur in elderly patients. They're frequently asymptomatic. They've got identical immunophenotypes, and they involve the production of high numbers of abnormal B cells. So CLL shows significant bone marrow involvement, right? And that results in peripheral blood lymphocytosis. You'll see that absolute lymphocyte count over like 5,000 and or cytopenias. Now, SLL, now this is a type of non-Hodgkin lymphoma, and that's going to cause lymphadenopathy and or splenomegaly and show a normal or mildly reduced absolute lymphocyte count of less than 5,000. Now, the patients, and they also, have anemia and thrombocytopenia. So there's your, you get to your diagnosis. Now you have to, you get to the mechanism here. So CLL and SLL, these all originate from B cells. And they normally produce antibodies in the humoral immune system. And these malignant B cells are abnormally fragile. And they've got a very distinct immunophenotype. So they'll express lymphocyte markers, CD5, CD19, CD20, CD23. Now, CD5 is generally a marker for T cells. It's also seen in the malignant B cells present in CLL and SLL. So when a peripheral blood smear is created on this type of patient, many of these really fragile lymphocytes, they get damaged in the process. So that creates the smudge cells that you see there, kind of circled in the that we've got here in the image. Okay, so you can see where those smudges are. So again, good question, tough question, right? And hopefully you guys can see where those smudges are. You can kind of see ones. I'm going to grab my pen here just to make sure you're seeing it here, right? There's a good smudge. There's a good smudge. Okay. So let me erase all of my terrible drawings. Okay, great. So let's look at those other answer choices, because all of them got plenty of votes. So what we need to kind of think about it, what you would see here with those. So for T lymphoblasts, an abnormal population of T lymphoblasts would be suggestive of T cell acute lymphoblastic leukemia, or T-ALL. But the patient's age and clinical presentation here are going to make it less likely. For promyelocytes, if you're going to see an increase in promyelocytes, that would be characteristic of APL, acute promyelocytic leukemia. But again, the clinical presentation doesn't quite align. Plasma cells, an abnormal proliferation of plasma cells is seen in multiple myeloma, but clinical presentation not really suggestive of that here. In metamyelocytes, if you see large populations, those more indicative of a myeloproliferative disorder, which isn't quite consistent here. Okay. So again, the big key here is the blood smear and seeing those smudge cells. Okay. So well done, everybody. This we're going to count it as a win, and we'll see what we can do here to close it out. We've got one more question. Get back to my pointer. So we've got question number 4. Final question. Again, we're going to have a raffle here after this, and a couple of special reminders. So again, we've got the answer choice covered up, and or all the answer choices covered up, and we're going to read that lead in. So which of the following is the most likely probability that the future sibling will not have SCID and have an identical human leukocyte antigen, HLA, match as a donor? Okay, so what does this mean? Yeah, we've got a little bit of math to do in this one, right? So you know that. Now we can go and read the vignette. The parents of an 8-month-old boy with adenosine deaminase deficiency, severe combined immunodeficiency, come to the immunologist to discuss hematopoietic stem cell transplantation as a treatment option for their child. The mother is currently pregnant. The parents would like to know the chance of their pending child being able to serve as a donor of hematopoietic stem cells. Lots of questions here, right? Potentially ethical questions. So, but let's read this again and think about the probabilities. So again, which of the following is the most likely probability that the future sibling will not have SCID and have an identical human leukocyte antigen match as a donor? Okay, so with that, let me know how many steps you think it will take to solve this one. And just kind of looking at it again, there's, you've got all of the information in here. So what we're going to need to do is just start, I think we just need to start putting out the numbers, right? Okay, so let's open up the slide here so we can see. So what do you think the probabilities are here? 3 and 16. Answer choice E, 3 and 16. Answer choice D, 1 and 8. Answer choice C, 1 and 4. Answer choice B, 1 and 2. Answer choice A, 1 and 16. Okay, let's think about those probabilities. Just giving you another few seconds to look at this before I launch the poll. I'm going to launch it right now. So you got a bonus SCID question tonight. I wanted you to look at that question a little bit longer because the actual lead-in was so long that it went beyond the character count for GoToWebinar. But again, that question, which of the following is the most likely probability that the future sibling will not have SCID and have an identical human leukocyte antigen match as a donor? Okay, so go ahead, take a shot. One thing to keep in mind here is that we often remind you that on test day you're going to have some questions that are going to maybe trip you up, maybe things that you're just not you can't remember, you're just not comfortable with. Make sure you answer every choice or answer every question on test day. Okay, there's no penalty for it. Tao will talk about that tomorrow night, in fact, but often what we'll suggest is you just you figure out the answer choice that you're going to use every time that you hit one that you're unsure about, where you feel like you're really just kind of taking a stab in the dark. Okay. So let's see, we've gotten almost 3/4 of you voted. Let me just open it up. I'll keep it open for just a few more seconds. Then we're going to close the poll, okay? Okay, so I'm going to close the poll, and let's look at the results. Okay, so again, all across the board here, so we've got a little over a third of you went with 1 and 4 as the probability, and then almost it's pretty much even for the rest of them. Right around 15% for all the other answer choices. So interesting, obviously, tricky question here. So we're going to hide the results, and let's get the slides there so you can see it. And the answer is answer choice E, 3 and 16. So answer choice E didn't get that many votes. So it's clear that this one a little bit tougher. So that's okay. That's why we're here. We're gonna kind of walk through this. Okay. So and I've got the formula down here at the bottom, but let's just kind of walk through it. So SCID can be inherited either as an X-linked disease or an autosomal recessive disease. So autosomal recessive forms of SCID, that includes ADA deficiency, JAK3 mutations, interleukin-7 receptor mutations, CD45 deficiency, you name it, ZAP70 mutations, reticular dysgenesis. Interleukin-2 receptor G mutation is the only form of X-linked SCID. So because this patient has an autosomal recessive disease, the chance of inheriting an autosomal recessive disease is 25%. Therefore, the future sibling has a 75% chance of not having ADA SCID. Okay, so that's the mechanism. So now we take that and we say, okay, well, what's the normal function here in the world of genetics? So human leukocyte antigens inheritance. This follows the Mendelian rule of inheritance. So you got a 25% chance of inheriting all of the same HLA, the same two haplotypes as a sibling. And you've got a 25% chance of not inheriting any of the same HLA, which would be none of the same haplotypes. And you've got a 50% chance of sharing one haplotype with siblings. So a person has a 1 in 4 chance of being an identical match with siblings. So the chance of having or not having ADA, SCID, and being HLA identical are independent events. Okay, so you're going to have to take the odds here and multiply them together to determine the chance that the sibling is both disease-free, so your chances there, 3 out of 4, and HLA matched, which is 1 out of 4, right? So in this case, you would take, 3/4 times 1/4 to get 3/16. So the future sibling has a 3 in 16 chance of being an HLA matched donor for the patient. Okay. So looking at the other, answer choices here, looking at what do we got here? The 1 in 8, that would represent the probability of the future sibling sharing an X-linked disorder and sharing identical HLA. 1 in 4 represents the probability of the future sibling not having a disease caused by a de novo mutation and sharing identical HLA. The 1 in 2, because the HLA follows Mendelian inheritance, there's at most a 1 in 4 chance of being an identical match with a sibling. So it's not even possible for a sibling to have a 1 in 2 chance here of being a donor. And then 1 in 16 represents the probability of the future sibling having the autosomal recessive disorder and sharing identical HLA. Okay. Tricky question, hard question. We save the worst for last, right? But appreciate everybody here hanging in there. And I know this is kind of a long, torturous explanation. Keep in mind that we do post recordings of Question Lab up on YouTube, so we can share more of that. You can try to rewatch some of that there in later on this week. Okay, but overall, great job. You guys did a bang up job tonight. Here are the question IDs. So take a screenshot of this if you want to take a look at those questions again and see all of the explanations in even greater detail, as well as the references to the bricks and where you can find some of that information in first aid. We've got it all there. Okay. So want to just note we've got all kinds of different places where you can find us. Make sure you're following us on Facebook and Twitter and Instagram. We're always putting up questions and flashcards, flash facts. We're putting up videos from our webinars and from the podcast. We're also up on Threads and TikTok. So those are, platforms that are, everyone's on TikTok. So we've got some of the videos that we include for our case connections each week, as well as some of our questions, and then all of our question labs and webinars are found on YouTube, along with some of our express videos. So plenty of ways for you to follow us.